All right, here we go. Thank you guys for joining us. Today is the first webinar in 2022. So thanks so much for joining. Um, we have a nice group already trickling in, so we can go ahead and get started. And we're gonna do it as usual. It's pretty informal. If you have cases, please feel free to just let us know, and we'll make sure to share them with the team. Does anybody want to start with their cases?
I have some case examples I was willing to show that I had assembled. Not a particular case, just sort of dealing with myocarditis.
All right, let me.
But if someone has a specific case, they can go first.
We can start with you, Greg. I'll make you presenter.
Okay. All right, now let me see
Maybe
here.
you
Hold
just
on.
share your screen. There you go.
Okay, hold on. Wait, screen two. Hold on. It's funny, it won't. Oh, there it goes. Okay. Are you seeing this here? Do you see this? Do you see the slide?
Yeah, we can see you.
Okay, great. Yeah, the reason I wanted to show this is because I know, there's old and new Louise Criteria. This is something we deal with all the time. I mean, there's a lot of data out there that talks about how the new Louise Criteria is certainly has higher accuracy for myocarditis detection. But the problem is it really includes a lot of sequences that adds on to the length of an exam. And even though we brag about our exams being short, sometimes I think we're in denial about how long those exams actually are. And so as we go through, we always start cutting things. So we really, I think, mostly just include sequences for the old Louise criteria purely out of just getting a patient on and off the table in time. And so I just wanted to just show some examples of that because a lot of times I notice that people will look at these studies and just sort of eyeball it qualitatively, but there's a lot of quantitative numbers there. And just to review, the three main criteria that we use are one is T2 signal, and so that has to be on a fat-sat T2 weighted sequence, and we're looking for a skeletal muscle to myocardium ratio of greater than 1.9, or you can have an area of adjacent pixels, 10 adjacent pixels that are more than 2 standard deviations above the mean. So I just want to quickly show an example here. This is a patient with myocarditis. Here's the LG area. Here was the fat-sat area, the T2 fat-sat, and the measurement, if you took all these pixels and compared to skeletal muscle, it didn't quite meet 1.9. But if you took those regions, for example, here of where you had LGE, this one did exceed 2 standard deviations compared to what we believe is a normal portion of myocardium. So that's just sort of the example. And that's also why I find T2s to be the least useful, and I'd like to hear from others, because I just find the quality on T2 sequences is often lacking compared to other things. The other is just early gadolinium enhancement. And for early gadolinium enhancement, you can look at myocardium to skeletal muscle ratio of greater than 4, or you can use these enhancement ratios here, where your skeletal muscle will go up 20% with contrast, but your myocardium will increase more than 45% with contrast. So both of those criteria, if both of those are true, then you have a positive criterion. And so this is an example of a person pre and post, and you can see how bright the myocardium is increasing with respect to, with respect to skeletal muscle in this patient. This is an example here of a person with this early gadolinium enhancement. This is basically imaging immediately after gadolinium contrast. This person actually had a lymphocytic myocarditis, so the RV. Some of you may have seen this case before. I know I've showed it. And that this was the degree of enhancement that they had in that RV area compared to, you can see the LV doesn't enhance quite as much. All right. Then, of course, everyone likes late gadolinium enhancement. In fact, that is the measurement with the best accuracy. Here's an example of a patient. Remember, it's always mid-myocardial or subepicardial enhancement. Here again, we have an example. I find the challenges with late gadolinium enhancement is often when you have areas of enhancement, it will blend into the blood pool. Even here, you can imagine if this enhancement were sitting in the endocardial surface, it approaches that of just the blood pool. And so you always have to cross-reference it with a steady state free precession image to make sure that you're looking at a piece of anatomy. Oh, sorry, this is the T28 fat set. Let me advance one. Sorry. You have to make sure that you're looking at a piece that is actually anatomy versus blood pool. That's why you always have to cross-reference with a steady state free precession image. This is just another example. I showed this earlier of a patient with a subendocardial, and usually it is along this inferior lateral and inferior wall. That's the most common location. That's how it's reported in the literature, and that's actually our experience as well. That's where we most often see it. And when you compare the old Lake Louise to the new Lake Louise, the new Lake Louise retains these T2 weighted early gadolinium enhancement and late gadolinium enhancement, but it adds these parametric maps. It's basically a way of creating an internal standard, or it just makes it a little more quantitative, but you can see that the gains are modest. So this is area under the curve accuracy here. You've got 84%, and this was the best study I could find on this. 84% with the original criteria, and late gadolinium enhancement alone is listed here. So yeah, 83% for late gadolinium enhancement alone, and for the new criteria, you only have to have 2, right? So you can see that when you add T2 mapping LG, you're about 90%. So you're sort of in the range, and that's why we're always having this problem of whether a patient can stay on the table and whether the exam is going long enough. But most of the time, we actually only include these first 3 in our myocarditis imaging protocols. I don't know about the other people on the call, Jacobo and Carol. What is your experience? Do you guys do all the parametric mapping on myocarditis patients? We occasionally do it, usually T1, almost never T2.
Carol here. Yeah, we always do parametric mapping on our myocarditis, and we don't do the T2 fat set or early GAD enhancement.
Okay.
We've given up. Yeah.
Okay. And why not? Why don't you do the fat set? Why? It's just quality is poor, right?
Time. Quality is poor, and time. Yeah, just trying to save time.
Yeah, we have the same experience down here. We're doing parametric, and yeah, just that's the thing with the T2 and FATSAT images. When they come out nicely, they're super nice, but it's so rare that they come out nicely. They're usually just
Very true.
Yes. Yeah, that's our experience. And I think Phil Young has this elaborate system of making sure he always gets high quality T2 images. But still, it just seems, it doesn't seem like a lot of people are able to replicate that. So, okay, well, that was it. That's all I wanted to show. Do I have to return it to you, or can you regain control, Jacobo?
On echo, and we were asked to do an MR. Hopefully my movies will start working here. So does anyone want to take this case?
What was the history again?
She was diagnosed with what they thought was an LA thrombus on echo. So I'm happy to show the images, or if someone, if there's a fellow on, or anyone who wants to volunteer to take the case. No takers?
Well, if no one volunteers, I'll risk embarrassing myself.
Ooh, okay.
Anybody want to volunteer? Okay. All right. Okay, so I'll go for it, only because, I think it may be an epic fail, but what I'm seeing is I'm seeing some abnormal jet originating from the middle of the left atrium. I'm looking at that 3-chamber view you've got, sort of a 3-chamber view, or 3-chamber / VLA view, and there's that jet you see that originating from, and it almost looks like it is there's like a line there, and I'm wondering if, could this be some sort of now the bottom left-hand image, I'm not sure what that is showing, but that clearly looks like some kind of abnormality. Right. So
That's
that looks like some kind of septum in the left atrium, right?
yeah.
And so when I see something like this, first thing that jumps into my head is some kind of core triatriatum. But at the same time, I feel like you would be showing me a better image because there's no real signal intensity in the blood on the other side of that septum. But that would be the first thing that would jump into my head. But there is some sort of septum there in the left atrium.
Yeah, certainly a narrowing there for sure.
Yeah.
Unfortunately, I don't have any T1, I don't know why, this is an older case, but these are the post-GAD images.
Mm-hmm. And there I see it again on the, I see that septum again on the right-hand image. The left-hand image is, yeah, that's a post-GAD. Well, maybe it's just a large thrombus causing a some sort of narrowing there because, or no, I'm sorry, not a thrombus. Although that is a magnitude image and there's etching around it. So I don't know if that's actually truly enhancing or not.
That's
Okay.
a PSIR on the right.
Oh, so it is enhancing. Well, then I think I would go with a sarcoma.
Yeah, very good. So yeah, it is enhancing, and it actually turned out to be a left atrial sarcoma, really not kind of the typical location for a thrombus, but it is kind of layering along the posterior wall of the LV. In fact, here it looks like it's circumferential. And I'll just go back. Here, the port chamber is a bit low, but you can see it filling the back of the left atrium here. And that movie won't go anymore. Anyway, you can see that narrowing is where the jet is emanating from. And here it's lining the posterior wall. So just, you know, it is definitely a tumor, but it's always difficult to know kind of the extent on an MR that you're dealing with and whether this is resectable or not. I find often they ask us to look for resectability, and it's not kind of until you do a CT that you really appreciate what's going on. And so this is CT in the same patient done a few days later. And I think you can appreciate the appearance of this aggressive looking tumor narrowing the pulmonary vein, ostia, and obviously does not appear to be resectable in a large pleural effusion on the right. And a pericardial effusion, which you could see on the MR. But important, I think, for us to know that to, you know, always recommend a CT to see kind of the full extent of the anatomy that's involved as opposed to the smaller windows that we typically have for MR. These are delayed images, and there was indeed some abnormal enhancement of the pericardium, and I think actually this is later on, probably a few months later, and you can see the spread of this thing into the pericardium with enhancement and soft tissue metastases or invasion into the pericardium. So just a reminder for if there are any juniors to not solely rely on the MR, always recommend CT when you think you're dealing with tumor. Yeah, so that's it. That's all I have today.
It's a nice case. Well, it's a good case. It's an unfortunate case.
Yeah. Any questions, anyone? Okay, I guess you can take over if you're able to, Jacobo, or? No,
well, just one quick question, Carol. What kind of a sarcoma was it on the path? Was it undifferentiated or?
It was undifferentiated, yes.
All right. Do you usually see, because there's some areas of really low attenuation, was there some fat in it?
No,
Okay.
but it does look like it. Yeah, from what I recall, it was not did not have any fat component. I think could be necrosis, but I agree that I think it looks quite low density. It's not quite as dark as fat, but almost there.